I didn't think that we have a lot of patients who can match this category of outpatient. Okay, let's talk about something better. In our setup, we need to more early mobilize our patient. This is actually the main goal of the discussion. Early mobilization of the patient. And I understand the multimodal, it's a golden standard for such procedures. Unfortunately, we don't have any universal agreement which kind is suitable. So we keep the range open for everyone to select what is suitable. You, Dr. Ibrahim, has experience with sciatic block along with spinal. This is your preference.
Yes.
Maybe others, they prefer combined spinal with Europe. The others prefer to give morphine BCA with a spinal, whatever. The other category which we're facing sometimes, most of the times, in my hospital, we usually, for sake of some patients, they are at high risk and they offer by the surgeon sometimes to do bilateral TKR. Again, doing a block for bilateral TKR and early mobilization, I think quite difficult, right? So still we need to face such a...
Actually, there's two schools, orthopedic schools regarding doing unilateral or bilateral.
No,
and none of these schools say proven to be superior on even unilateral only has good outcome or bilateral has outcome. But most of the centers, they are doing total knee replacement as an outpatient procedure. They are doing for unilateral cases, not for bilateral.
But I'm talking about our setup again. Still, maybe Ryan is still quite different than others because most of our surgeons, they are senior surgeons like Simon and others. They usually do bilateral TKRs. And during last week we did almost 6 or 7 bilateral TKR in one week. So again, doing blocks and to early mobilization bilateral patient, there is a question. Can we apply it in the setup? Bilateral TKR, we give another
Dr. Ibrahim and we can answer this.
Yeah, I will give a list of questions and I will
This
give
is the
you
practice we are already doing already.
Since 3 years we are doing.
If you have time, I can show you the Instagram of one of our surgeons. He's showing one bilateral patient moving 2 hours after the surgery with bilateral casters, pain-free.
We'll cover that. I will open all the questions for you, for all of us actually. The other issue, I need to clear it up actually. Excuse me everybody, I want to get a cut. Again, we are facing sometimes that to give a single shot, block or a continuous infusion. Keeping catheter, it's not willing accepted by some surgeons and even some patients. They think that once the catheter is there, we should not mobilize the patient. And nurses in our hospital, usually once they find a catheter, whatever kind of catheter, they hesitate to move the patients because they feel it's a risk of fall, and most patients fall if they come under that shot. So again, keeping a catheter or a single shot box where we are, is it better or convenient for our client, for our patient, for our setup? I'm not talking about whatever applied. So we need to modify it based on HMG setup. Again, we have facing some problem leaving a catheter, and sometimes, if I have a single foot drop in any one of the incidents, it's a source of conflict. So whatever I'm saying, it's open for discussion actually. I just keep questions, and I leave everybody to answer. Okay, and maybe our colleagues sitting, maybe they have other options.
Regarding casters, it's like a culture of the hospital and how the team of the hospital used to. Our team in the hospital, actually, when we send the patients, when we started the local infiltration technique, maybe 4 or 5 months ago, we tried in maybe 2 or 3 patients. One of our surgeons requested, don't put casters. Please, we will give only periarticular infiltration and we will see. When we send the patients to the ward, the nurses become panic. How you are sending patients? We have here some of our team, pain team. How you are sending patients without casters? Patients will have a great pain. The patient, they were getting panic. Actually, the periarticular infiltration give us about 48 hours, patient pain-free. But after the 48 hours, patients start to scream from pain. And even the IV analgesia and other opioids didn't get to maintain the pain control, and even the pain delayed some sessions of physiotherapy, because the patient in pain, you cannot force him to walk. But if the patient pain-free, muscles can move. So immediately, and some of our patients, only 2 hours after the operation, we're asking them to walk, to move and walk. Okay, so I think that the caster value, it doesn't appear on the first day or second day if you're going to give a periarticular block. The value appears on the third day. And usually we keep these casters for 4 or 5 days. And the first 4 or 5 days are the main timings that the patients actually need a good coverage of pain control. My idea now, we are forcing our pharmacy to provide Exparel, because according to literature, they are saying that Exparel is giving 5 to 7 days of pain control. And if we get this drug and we start the periarticular infiltration with Exparel, we don't need to put casters again. And I think in my presentation here, I showed some meta-analysis, and this meta-analysis done on 702 patients. It was discussing about 8 papers, comparing the single shot with casters, and it says that the casters are better in controlling pain on long term, not the single shot value. It's on the first 24 hours. Is on the first 24 hours, but as a continuous nerve block value actually comes from second and third day and are coming to the fifth day. Do you have any other opinion, Dr.
And we are losing on the basic, idea that we are going for enhanced recovery after surgery for knee surgeries. And if you introduce opioids, you're increasing the chances of. We've tried it actually in such patients. In these patients, because me and Dr. Ibrahim, he's the leader, and me and Dr. Tabi, we deal with these patients after the surgery, and we had complaints that they are screaming with pain. And once we put them on patches or any opioid PCA, they are stuck to the bed. They are not mobilizing. So you are ultimately failing on your goal of enhanced recovery after the surgery, which is the surgeon wants. The surgeon wants to promote himself or market himself as a proponent of outpatient DPR or something, and then we are losing when we put PCAs or opioid patches. We have patches, we have buprenorphine, we have fentanyl patches in our hospital, but we are rarely using them.
So you are a strong believer in single shot or infusion?
No, infusions, continuous infusions, better, because we are able to manage the patients, especially the third day or fourth day.
Yes, I guess just the mic for the online thing, because they cannot hear the attendance.
My experience is slightly different because I having trained in England 10 years ago is when I started working in orthopedics as an anesthetist, and the experience then was high volume local anesthesia, filtration with single shot injections, and for rescue, which is a PCA. You would only use rescue for about 5 to 10% of cases. It seems things have gone full circle in our department. When I came, everyone was getting an epidural, and now 10 years later, we're starting to go back to high volume local anesthesia and filtration. I think with the idea of catheters, they're good, but I think the long-term solution, if Exparel is available, is just single shot. And
we have already.
Okay, what about single shot with Dexa, with the steroid?
Steroid actually is not approved in all textures. All meta-analysis speaking about additives, the only proved additive is adrenaline. Other additives, only studies covering this.
Sorry, I have to tell you something. In my experience, I have done total knee arthroplasty. I'm doing it since 2002, and I have a personal experience with
It's okay.
total knee arthroplasty.
You need to keep it.
For my experience, I will respond to your question. Doing sciatic block, no, I will not do it. For the simple reason that
Try it with Rubic.
no. I will not do it because the procedures, surgical procedures, sometimes they can't cut the perineal nerve, and after you can have a foot drop due to surgical reason. So if I do sciatic block and we have foot drop, I don't know now if this is my block or this is the surgery. So that's why every surgeon, if you see, he check the artery and then the movement, and he wants to see his patient move. That's why I don't do sciatic. In 2005 maybe or 6, we have done only tibial, single shot on tibial branch. But even with that, we had a problem for ethical and for complaint, foot drop. We don't know now who is responsible. So for this reason, we don't do sciatic block for total knee replacement.
You're giving guidance.
This is clear and cut.
What's your option?
My option, I will finish by my option.
Yeah.
Okay. Second question, doing bilateral total knee? No, we don't do bilateral total knee. Why? Because we don't have any advantage to do bilateral. The only things that we will do, we will increase the risk of fat embolism at 72 hours after the surgery. And you will find your patient collapsed in his bed, and nobody know why this patient is collapsed. That's why I'm fighting to not do bilateral total knee. I'm doing maybe over the year I do 1 or 2 cases because I couldn't convince the patient or the surgeon to do one side and then the other side. And I have seen. I will not tell you that I have seen a lot of people, but I have seen people bilateral total knee arthroplasty collapse at 72 hours and know it is fat embolism. So I don't accept to do bilateral total knee arthroplasty. This is for good.
What about surgeons?
About surgeon?
How do you measure this?
But evidence-based, there is no difference between them till now.
Yeah.
Evidence-based,
but this is what we
either
have.
to do it
The
unilateral or bilateral, there's no difference.
the third question is continuous or single shot. I'm with single shot, honestly. I'm with single shot. Why? Because risk of infection also come again. Number 1. If it is my catheter, I don't know. If it is the surgeon, I don't know. Okay? But it's easy to complain that our catheter put the infection. Do we need the catheter? No, we don't need the catheter. Why? Because we can manage pain with single shot. I'm doing this since 2002. Okay, now we improved. We started by the femoral block, then after IPAC, then after injection, then after actually we are doing an adductor canal. Can we compare adductor canal with low dose femoral block? No, we cannot compare. I'm sorry for you. Why? Because that's the question that we need to ask. Are we doing adductor canal for this patient? Actually, no, we are not doing. Because we don't know people what they are doing. What we need to do. Are we doing upper adductor canal or inferior femoral triangle? We don't know. Are we doing intermediate adductor canal? We don't know. Are we doing lower adductor canal? We cannot compare lower, intermediate, and upper and inferior femoral triangle with femoral block. Okay? So, for the time being, the recommended is doing intermediate adductor canal with single shot. Okay? Now it's up to you what you want to put in this adductor canal. Plus, in this adductor, you want to do exparal, long acting, short acting. I'm doing interventional pain management since 2000. I'm doing genicular block with dexamethasone for the patient who are not able to operate or not ready to be operated for the knee. Okay, and it's relief pain correctly. Okay, so I get the option to put bupivacaine plus dexamethasone. I'm sorry for it. It lasts 5 days.
Last how many days?
5 days.
How will the cane last for 5 days?
5 days.
How?
It's not the bupivacaine, it's the
The
dexamethasone.
pharmacokinetic of bupivacaine cannot stay for all this time.
I can come to your branch and show you what I am doing. Single shot, adductor canal. Now the question, what adductor canal I have to do? I have to do the intermediate canal, the intermediate adductor canal. Intermediate adductor canal, there is a trick there. There is your vastus intermedius and vastus lateralis, some nerve, some that governing the lateral and the medial part of the knee. Sometimes they are not. They are not in the canal. They are also they are before the canal, outside of the canal. That's why I need to put Subsartorial injection. I put 5 cc subsartorial and 15 cc in the canal, and that's it. The canal, I have to see the abductor, I have to see the sartorius, and I have to see the vastus medialis. This is the canal and the artery. Okay, this is my personal experience. This is what I'm doing. My block lasts 5 days, and my patient all are happy.
Can I have a small comment? I think controlling pain is very different than stopping all the pain. If you are seeing patients with pain score 3, 4, this patient is still under control. But actually with our technique, and we are doing about 50 or 60 cases per month, in our technique, the performance we are doing is that we reach that pain score becoming 0 for 4 or 5 days. Patient doesn't feel pain at all. Patient can walk, can do their physiotherapy without problems. That's the performance we are doing now. But you can say, and our patients also, if they need a rescue dose of opioids, it's very less. It's very uncommon to give them some opioids. And usually, when we give opioids, we give for posterior pain after the second day or third day, and not for anterior pain. Anterior pain is 100% no pain for at least for the 4 or 5 days, which is the caster inside. So I think our target is to reach no pain, not controlling pain. There's a big difference between pain controlled and no pain. I'm against that bupivacaine can stay 5 days in the body. It's against the pharmacokinetics of the drug. The drug itself will be metabolized and it will not stay in the body for 5 days. You can say control of pain maybe 24 hours, 36 hours. When we are giving a TAP block and we are promising the patient that you are going to be pain-free for 2 days, I think we are over-exaggerating. The TAP block actual efficacy, and it's proved by evidence-based, we are speaking about 18 hours to 24 hours. But 2 days is too much, and by speaking now, a doctor can have for 5 days is against, I think it's against the pharmacokinetics of the drug itself.
We are talking about bupivacaine here, we are talking about dexamethasone.
Dexamethasone, actually all the additives, evidence-based, all the additives to the local anesthesia are not proven that they are extending the time of the local anesthesia except adrenaline. If you are speaking about magnesium, clonidine, we are putting these additives as, there is some studies supporting these additives, but evidence-based, there is no strong evidence that these additives can prolong the effect of the local anesthesia. Also, there is another study, I think you are aware about it, Dr. Omar, which is comparing giving dexamethasone as an intravenous I think most of us knows about this drug. They're comparing dexamethasone giving intravenously or with the local anesthesia, and they say both are the same. There is no difference between giving dexamethasone.
This is Faraj Abdullah, a very time study that they have done. They saw that IV is same.
Partly the answer lies in the neurolysis by dexamethasone after 2 days. The dexamethasone starts to work after 2 days. What they say is the steroids action starts after 2 days or 3 days. This is the reason maybe you are experiencing. But in these 2 days,
injecting all the day dexamethasone.
I think if the session is too hot, and keep it hot, and we'll keep the further questions for
Yes, anybody has another question?
Maybe we need to, there is the questions there.
The criteria that we take into consideration
We
for
have the
1 day
hotline,
surgery.
but, I think there is
Can they protect us medically if a problem occurs at home?
Yeah.
Okay, medico-legally, there is no law that says that total knee patient shall stay for 2 days, 3 days, 4 days. There is no fixed law regarding this. The medico-legal aspect here is about patient safety. If you are going to discharge your patient, is your patient is going to be safe or not safe? And I remember the question with Dr. Nasser said in the beginning of his talk that how many patients will be benefit of this outpatient procedure. If we remember on my slides, I said about 5% of the patients done worldwide in the state
I'm
in
saying in
2000.
our setup. Sorry.
In our setup,
I'm saying in our setup.
Dr. Nasser,
cultures.
during the last 6 months,
Mm.
I remember maybe 3 or 4 times, I find a surgeon coming to me, if you remember Dr. Tabi,
Yeah.
and he's asking, Brahim, I want this patient to go home tomorrow. I tell him, how tomorrow? If you are going to send this patient tomorrow and we don't have an outpatient project, this project is not an anesthesia project only. This project is anesthesia plus surgery plus patient education plus physiotherapy. It's a complete project. We cannot apply this with only anesthesia. We can apply this with multi-factors. If we have all these multi-factors, all the setup, and we can
Which is not mature now.
now we are not. Yes, we are not. We are not. We are
Doesn't
not.
matter.
We are not completely in our facilities. We are not. We don't have yet the complete facilities to give this service. But what we want that when a surgeon or a patient, and it's proven by evidence base that the outpatient outcome is better than an inpatient outcome. If we are requested to do the service is available. We have the service available. So my hope that our hospitals start to make a setup to give the service whenever needed.
I think to expand on what Dr. Ibrahim is saying is, and answer your question, is it possible in our setup? I think we have to look into the possibilities. Why? Because there's a prince who had day surgery, and all patients coming for knee replacement are asking their surgeons about it. Can I have it the same as this patient? This is the
And
answer.
the surgeon, by the way, is using experiment.
And this is an SFC.
There's a lot of factors actually. Sometimes